Good morning, everyone. I hope every one of you is keeping safe during these challenging times, and I wish you all very good luck. Well, in the next few classes, I'll be discussing with you about glaucoma. The first important thing in any disease process is its definition. So, as you people must be knowing that glaucoma is defined as a progressive optic neuropathy with very characteristic changes in the optic nerve head. Okay, optic disc is basically the head of the optic nerve. So there are very characteristic changes in the optic nerve head, and these changes reflected very well in the visual fields of the patient that we can examine with the help of certain equipments we have. And the third important thing is intraocular pressure, which may be on the higher side, it may be normal, or even on the lower side. So it is not necessary that intraocular pressure has to be high to diagnose glaucoma. Now, to understand a disease process better, we need to know the anatomy and physiology of the involved system. And for glaucoma, it is the angle of the anterior chamber. It is basically a recess formed between the posterior surface of the cornea and the anterior surface of the iris. And you can see over here, this is an actual picture of the angle, an anterior chamber angle. So this is the posterior surface of the cornea, and over here is the iris. So this angle recess between the posterior surface of the cornea and the iris form the recess, and it consists of certain structures. So if you go from anterior to posterior, the first structure that you come across is shawl baseline. It uh, it is a very sharp demarcation over here, and it marks the end of the Descemet's membrane. It is an important landmark in the angle. The next is trabecular meshwork. As you go posterior, you come across trabecular meshwork, which has got two parts. The anterior is non-pigmented trabecular meshwork, and the posterior is pigmented trabecular meshwork. Then again, there is a very fine white line, which is scleral spur. And last but not the least is slitty body band, which is a dark brown band between the scleral spur and the root of the iris. So these are the structure which comprises an angle. These are the stepwise diagram of the angle. In the first one, you can see there's an area bounded by two lines. This is an area of the limbus, and underneath it lies the angle. You can see over here, there's a very prominent elevation. This is scleral spur, and again anteriorly there is a prominent elevation. This is the shawl baseline, and between these two there is a well formation. This is the scleral sulcus, and in the second figure you can see that this area is bounded by trabecular meshwork, and then it forms the Schlimm's canal. Schlimm's canal is connected to the outside episcleral venous plexus with the intrascleral channels, or also known as collector channels. In the third figure, you have slitty body in place, and in the fourth one, rest of the structure like iris, lens, and the zonules. So this is the composite picture of the angle. The next one is the ultra microscopic figure of the angle, where different parts of the trabecular meshwork are shown. Trabecular meshwork comprises of three parts. The outermost is the uveal meshwork, which is in direct contact with the aqueous. The middle one is corneoscleral meshwork, and the innermost is the juxtacanalicular meshwork, which forms the roof of the Schlimm's canal. The Schlimm's canal, you can see over here, is connected to the collector channel. Now the aqueous, as it drains out of the eye, it follows two important routes. The first one is trabecular outflow, which accounts for around 90% of the aqueous drainage. So as the aqueous is formed in the slurry processes over here, it goes into the posterior chamber. Posterior chamber is a space bounded anteriorly by the iris and the anterior surface of the lens. From the posterior chamber, it goes through the pupil in the anterior chamber, and from there it goes in the angle, and it passes through the trabecular meshwork, then goes to the Schlimm's canal collector channel, and then goes outside of the eye. The other route is uveoscleral outflow, and it accounts for around 10% of the aqueous drainage. The uveoscleral outflow is when the aqueous goes in the suprachoroidal space, which is a potential space between the sclera over here and the choroid. So it goes into the suprachoroidal space, some of it absorbed in the choroid itself, some goes through the sclera. You can see over here it goes through the sclera, and some of it goes through the emissarial canals, which are present in the, these are very fine vessels, emissarial vessels, which goes through the sclera, and the aqueous passes through it. So these two are the important aqueous outflow. The next important thing is the physiology of the aqueous humor formation. And the aqueous humor is formed from the non-pigmented slurry epithelium of the slurry processes through three different processes, the most important of which is active secretion, which accounts for around 70% of the aqueous formation. The other two are ultrafiltration, uh, that is responsible for 20% of the outflow, and the rest is through osmosis. The total volume of the aqueous in the anterior and the posterior chamber is around 0.3 ml, and the rate of formation is 2 to 2.5 microliter per minute. Now, as far as the pathogenesis of the glaucomatous changes are concerned, there are different theories have been given in the past, and two most important theories that came out are the mechanical theory and the ischemic theory. In mechanical theory, it has been said that it is because of the direct compression of the aqueous, because of the increase in intraocular pressure, there is the exertion of the pressure on the axonal fibers and the support structure of the optic nerve, which eventually distort the lamina cribrosa, and it interrupts the exoplasmic flow, causing death of the retinal ganglion cells. This theory is good if the intraocular pressure is high, but it does not explain glaucomatous changes in those cases which have normal or low intraocular pressure. So another theory was given, that is ischemic theory, which focuses on the intraneural ischemia resulting from the reduced optic nerve perfusion, either because of the increase in intraocular pressure or some intrinsic process of the optic nerve. So these two theories are important as far as glaucomatous damage is concerned. Now, the next thing is to classify this disease. There's a long list of different etiologies of glaucoma, but it is basically classified as congenital, which may be primary congenital glaucoma or developmental glaucoma. There may be acquired glaucoma, in which first one is primary open angle glaucoma, which is without any ocular or systemic disorders. It can be chronic open angle or a normal tension glaucoma. Then we can have angle closure glaucoma, again without any known ocular or systemic disorders. It may be simple pupillary block glaucoma, or there may be some combined mechanism which can lead to angle closure. Then there are secondary glaucomas. It is not primary because of the changes in the trabecular meshwork or the closure of the angle, but it is secondary to some other cause. So there are different types. It may be because of the disorders of the corneal endothelium, where you can have iridocorneal endothelial syndrome, PPD, that is posterior polymorphous dystrophy, Fuchs endothelial dystrophy. Then glaucoma can occur due to disorder of the lens, like pseudoexfoliation syndrome, cat glaucoma because of cataracts, and then because of the lens dislocation also glaucoma can occur. Then glaucoma may also be seen in disorders of iris and ciliary body, like pigmentary glaucoma, iridocysis, plateoiris, iris and ciliary body cyst. There may be diseases of the retina, choroid, and vitreous that can lead to glaucoma, like neovascular glaucoma, which is very commonly seen in diabetes. Glaucoma can also be seen post retinal detachment or some abnormality in the vitreous. Then secondary glaucoma can also occur because of intraocular tumor, like malignant melanoma, retinoblastoma, metastatic carcinomas. Some benign tumors and leukemias can also lead to glaucoma. Elevated episcleral vena pressure is seen in certain diseases like Sturge-Weber syndrome and thyroid ophthalmopathy. So these can give rise to glaucoma. Post-uveitic glaucoma can also be seen. Uh, Certain individuals are responsive to steroid, and it can lead to increase in intraocular pressure. It can be seen after trauma, or if there is hemorrhage in the eye because of trauma and diabetes and other diseases where hemorrhage can occur. It can lead to glaucoma. And last but not the least is glaucoma following intraocular surgeries. So any intraocular surgeries in predisposed individual can lead to malignant glaucoma. It can be because of pseudophakia or aphakia, and so many other surgeries that can lead to glaucoma. Now, to diagnose a case of glaucoma, we need a thorough evaluation of the eye. So, the first thing that we do is the examination of the optic disc. Here you can see this is a normal optic disc head, and this is representational diagram which shows a neuroretinal rim. Neuroretinal rim is this area uh, which is between the outer boundary of the optic disc and the inner optic cup. This is the cup area and this is the optic disc margin. So area between these two is the neuroretinal rim. So a healthy neuroretinal rim is pink in color, and then there is this central cup. The horizontal diameter of this cup is less than the vertical diameter. Usually it is horizontally oval, and these are the blood vessels, the different blood vessels, arteries and the veins. Now we have a disc which shows definitive glaucomatous changes. There are different signs which are present in a glaucomatous disc. You can see over here there is because of the death of the retinal ganglion cells, the neuroretinal rim thins out. Initially, it is the inferior and the superior part which thins out, and the cup become vertically oval, and this is known as Hoyt sign. Then also you can see bearing of the blood vessels. What happens is when there's a loss of the ganglion cells, the cup deepens, and the vessels, the overlying vessels, appears to be hanging in the air. So this is bearing of the blood vessels. The increase in cup size, normally the CD ratio is around 0.3, uh, and over here it is around 0.5 in this one. And this is again very marked thinning of the neuroretinal rim. The cup to disc ratio is zero point 0.7 to zero point 0.9, and because of the retinal ganglion cell atrophy, these pores in the lamina cribrosa, they become very prominent, and this is known as the lamellar dot sign. There may be some shifting of the blood vessels on the nasal side, and another important sign is the bennetting. Bennetting is the sharp deflection of the blood vessels along the neuroretinal rim margin. Again, it is because of the deepening of the cup. These are the different important signs of the glaucomatous optic disc. You may sometimes find splinter hemorrhages, especially in normal tension glaucoma. Then atrophic zones around the optic disc may be seen. The inner one is zone beta and outer one is zone alpha. It's also suggestive of glaucoma. And if these changes are present, then the progression of glaucoma is said to be rapid. So this is again a representational diagram of different stages of glaucoma. This is normal appearing optic disc. Then there's a focal loss of the retinal ganglion cell, which give rise to a notch, a very characteristic of glaucoma. A diffuse thinning of the neuroretinal rim over here. You can see neuroretinal rim appears normal, but there is a deepening of the cup, like this saucerization or excavated disc, again suggestive of glaucoma. Then there may be nerve fiber layer defects. Okay, and you can see in the next figure, these are the nerve fibers. White striations are the nerve fibers which are coming to the optic disc. We can see white striations over here, white striations over here, but in between these striations, there is a clear area. So this is an area with the loss of the nerve fiber. And in red-free images, you can see this area very clearly. This wedge defect is loss of the nerve fiber layer. Another important examination is the examination of the angle. As you can see over here, this is a diagram showing different structure of the angle, slitty body, scleral spur, two parts of the trabecular meshwork, and shawl baseline. This one is an actual picture of gonioscopic picture of the angle, showing a slitty body, scleral spur, trabecular meshwork. Shawl baseline though is not very clearly visible, but it is anterior to the trabecular meshwork. So it is very important to gonioscopy is used to differentiate between an open angle and a closed angle. So this where you're seeing all the structure, this is suggestive of open angle. Now you can see in this figure that no angle structure is visible. So this suggests that the angle is closed, and in these cases, once we find angle to be closed, we do another examination technique, that is indentation gonioscopy, where we press on the cornea and that pushes the aqueous and it makes it way out through the angle, and certain structure may become visible. So now you can see this is the same eye, no structure is seen over here, and after indentation gonioscopy you can see over here, that is trabecular meshwork is seen. So this is after indentation gonioscopy. There are different grading techniques of the uh, angle. Um, so we'll discuss it later on when we deal with the individual glaucomatous entities. This is very important. Automated perimetry. Autoperimetry is used to uh, make out the changes in the visual field of the patient. So in this area, you can see these dark spots are seen. So these changes we come across in glaucoma. This one is a nasal step. It is the very earliest sign of glaucoma in perimetry. Then again a nasal step going to the disc. This is an arcuate defect over here. Centrocecal uh, scotoma or paracentral scotoma. A dense arcuate defect. This is a total defect with central tubular area which is spared. These are seen in very advanced stages of the glaucoma. The important thing to note here is that in glaucoma, the changes they don't cross the horizontal midline. If it's crossing the horizontal midline, that if the defect is crossing the horizontal midline, then it's not because of glaucoma. So a glaucomatous damage always respect the horizontal midline. You can see all over here, it is respecting the horizontal midline. And here you can see that horizontal midline is violated. So these changes are seen in neurological diseases. Like over here you can see on both the side there is an enlargement of the blind spot, which is seen typically in glaucoma. This is a homonymous hemianopic defect. Bitemporal hemianopia here is seen. A large central scotoma is visible over here. And then again a centrocecal scotoma which is extending from the disc to the center of the visual field. This dense peripheral defect is a rim defect which is commonly seen with the high power lenses that are used during the perimetry. And these spiral defects are very characteristic of in cases with malingering or hysteria. So you can see over here that the midline is horizontal midline is violated. So these are because of the neurological changes. These are the actual fields layout that we get after the visual field examination. A different part of the visual fields. This is the gray scale which gives a gross idea about the changes of the glaucoma. And then there's pattern total deviation and pattern deviation plots over here. And these are the changes that we see typically in case of glaucoma. Very dense superior arcuate defects are seen on both the sides. You can see over here. So this is what an actual visual fields looks like. And to diagnose a case of glaucoma on the basis of autoperimetry, we follows Anderson criteria. So there are three criterias that we need to fulfill the diagnosis of glaucoma. The first one is glaucoma hemifield defect or glaucoma hemifield test. What the autoperimeter does is it compares 5 predetermined points in the superior and the inferior field. These are the 5, 1, 2, 3, 4, and 5. These are the 5 predetermined point, and autoperimeter compares it. If there is any asymmetry between these two areas, then the glaucoma hemifield test is said to be outside normal limits. So this is the first criteria. The second one is that if three contiguous non-edge points, these are the three non-edge, this is the edge and these are the inner points. So three contiguous non-edge points on the pattern deviation plots which have a probability of less than 5%, and one point of them have a probability of less than 1%. This is the second criterion. And the third criteria is that the pattern standard deviation has a probability of less than 5%. So you need to have these criteria to be fulfilled to label it as a case of glaucoma, or glaucomatous change to be present in a field. Last but not the least is OCT, that is optical coherence tomography. Optical coherence tomography is a recent technique that we now very much utilize for in diagnosis of glaucoma. It maps out the optic disc and it gives you actual values of the thickness of the different layers of the retina and the thickness of the nerve fiber layers and other layers also. And there are different plots over here, and it compares these the findings that we get of the patient with the normal population, and then gives out you the these maps. These plots are given. So there are different color codings over here. You can see green area, yellow area, and the red area. If anything is in green, that it means it's normal. In the yellow area, it's borderline. If it's falling in the red area, it means definite changes are present. Then these are the quadrant maps: superior, nasal, inferior, and temporal quadrants. It is showing here in green, you can see. So this is normal, and on this side, this is OCT map of a patient with glaucomatous changes. So you can see the superior inferior quadrant maps over here. They are in red, so this is suggestive of glaucoma. Okay, on the right side, you can see the left side is absolutely normal. All of it is falling in the green area, but in the left eye, in the right eye, it is reaching up to the red zone. So these are the OCT maps that we get with the glaucomatous changes. So these are the important examination techniques that we employed for the diagnosis of glaucoma. So I think this is it for this class. Now we'll discuss in the later classes individual glaucoma entities and their management, diagnosis, and rest of the things. I hope you understand it well, and if you have any queries, you can get back to me on my email. Thank you.